everyone. My name is Shirley Li. I am associate professor and I am director of Clinical Pathology Services and the co-director of Clinical Chemistry and Toxicology Lab at the Ohio State University Western Medical Center. Today, I will be discussing how we translate global quality frameworks into actionable strategies in our health system using benchmarking and root cause analysis to drive improvements in clinical laboratory quality. Our focus will be on chemistry labs in a sixth lab system and how we standardize and improve lab quality. Here are my disclosures. I work with Siemens as a consultant, and I'm also working on some research projects, collaborating with Siemens. However, nothing is related with today's presentation. Quality in lab medicine is not just a regulatory requirement, but it's a foundation of patient safety and clinical effectiveness. In our case, we will walk through how we approach the benchmarking performance across all the six chemistry labs, the metrics we choose, and how we use them, and the root cause investigations to high-level metrics into actionable improvement. We will also look at why simply meeting threshold isn't enough. I will also show how deeper data analysis combined with site-specific features allow us to make more strategic system-wide quality improvement. Let's begin by discussing where errors typically occur in total testing process. Research and quality studies over the past 2 decades have consistently shown that the majority of lab errors, which are over 85%, occur in the pre-analytical phase. That includes everything that happens before the sample is analyzed, for example, patient preparation, specimen collection, labeling, transport, and handling. These issues can lead to inaccurate or delayed results and are often outside the direct control of the lab, but they have a major impact on test accuracy and reliability. The analytical phase, where we actually run the test, accounts for less than 15% of total errors. Thanks to advances in automation, instrumentation, and quality control, this is now the most reliable part of the process. But errors here can still occur, most commonly due to instrument malfunctions, calibration issues, reagent problems, or failure to follow SOPs. Finally, we have the post-analytical phase, also less than 15% of total errors. This includes reporting issues, critical value communication failures, delays in turnaround time, and improper data entry into the medical record. Understanding this breakdown is important for designing effective quality indicators. To truly improve lab quality and patient safety, we need to monitor performance across the entire testing process, which are pre-analytical, analytical, and post-analytical. Global frameworks, for example, ISO 15189, CLEAR, and CAP, each mandate some level of quality monitoring. However, translating these high-level principles into consistent system-wide practice is often challenging, especially in multi-lab systems. CAP recommends specific quality indicators and tracks proficiency testing. The IFCC, on the other hand, proposed a structured benchmarking model and identifies quality indicators across all stages of the testing cycle. This model is especially helpful in multi-lab settings where we want to compare labs fairly and identify systematic improvement opportunities. According to 2025 data from the American Hospital Association, 69% of U.S. hospitals are now part of a health system. The number continues to grow. This trend reflects the ongoing consolidation of healthcare organizations, where a single system may operate several hospitals, outpatient centers, and laboratories under one administrative umbrella. In this context, quality standardization across multiple labs within a system is no longer optional, but it's essential. Patients expect and deserve the same level of care regardless of which hospital or lab they go to within the same health system. That includes comparable turnaround times, accurate results, and a consistent quality of service. It's important that labs within the same system use consistent definitions, targets, and measurement methods for each quality indicator. Without this, it's difficult to compare data, identify outliers, or share best practice. For example, if two labs use different turnaround time targets or handle specimen rejection differently, you lose the ability to benchmark or drive improvements across the entire system. But beyond meeting expectations, standardized lab quality has practical benefits. It makes it easier to manage performance system-wide, streamlines oversights, and allows for more meaningful comparisons of test metrics like turnaround time, critical value reporting, and specimen rejection rates. Standardization also facilitates root cause analysis, supports harmonized training and procedures, and ultimately leads to more reliable care decisions across the facilities. When lab operates with different instruments, workflows, or performance standards, it becomes harder to pinpoint where improvements are needed or to implement system-wide quality initiatives. So, in a multi-lab health system, ensuring quality indicators are standardized is one of the most impactful strategies for driving better lab quality and safer patient outcomes. With health systems continuing to grow, quality standardization is both a challenge and an opportunity that we are addressing by aligning our lab around common metrics and expectations. To illustrate how standardization of quality indicators can be implemented in a real-world setting, let me share an example from our own health system. Our own health system includes 6 clinical chemistry labs located across different hospitals and care sites. Each of these labs serves unique patient populations, and they differ in size, staffing models, testing volumes, and even operational workflows. Despite these differences, they all perform overlapping sets of critical tests like troponin, electrolytes, and basic metabolic panels. So, in all of these labs, consistency in turnaround time, accuracy, and result interpretation is very important. In the past, each site may have monitored quality metrics differently. which means different ways of checking turnaround time or different thresholds for unacceptable specimens, for example. And this made it hard to benchmark, hard to find systematic issues, and even harder to improve performance. So we made it a priority to treat these six labs not as isolated units, but as a whole system. This means using the same platforms, the same definitions, and the same quality indicators target across all sites whenever possible. Once we decided to treat our six chemistry labs as a single quality system, the very first step we took was to standardize instrumentation across all sites. Here are the examples of the general chemistry analyzers. We use similar or even the same series of the chemistry instrumentation across all the labs. This decision was very helpful because if different labs are using different instrumentation or or different reagents or even different assay methods, it's impossible to compare the performance data in a meaningful way. Even something as basic as turnaround time or quality control performance could be influenced more by technical differences, but not true operational quality. By aligning instrumentation across all labs, for example, using the same chemistry analyzer models, harmonized reagents, calibration protocols, and the LIS interface, we are able to create a shared technical baseline. This not only made benchmarking possible, but also ensured that test results were more consistent across locations, supporting safer patient care, especially in cases where patients move between hospitals within our system. Once our instrumentation and workflows were standardized across all six chemistry labs, the next step was to define a standard set of quality indicators that we could use to monitor performance consistently throughout the system. We selected a set of indicators that span the total testing process. That means covering the pre-analytical, analytical, and the post-analytical phases, so that we can capture a full picture of lab performance, not just isolating issues. The core quality indicators we implemented include turnaround time, test volume, critical value reporting, specimen rejection rates, uh, and uh, uh, and the QC documentations, professional testing, and corrective reports. And we also have service occurrence reports or patient safety reports as a model to establish or standardize our quality indicators. Here is an example from our annual quality report focusing on stat troponin turnaround time. Um, at first glance, the data look great, but you can see here both CCL, which is critical care lab, and rapid responsible lab, they meet the common acceptable benchmark of having 90% of troponin tests completed within 45 minutes. However, the question I have is, should we be satisfied with simplify meeting this minimum threshold? Does this hit the target enough? Or can we push further to improve patient care? Meeting the threshold may indicate acceptable performance, but it doesn't necessarily reflect the optimal efficiency or the potential to reduce delays even more. Looking more closely at the data, we observed some important differences between our labs. For example, the rapid responsible lab show a clear improvement in troponin turnaround time performance in 2024, while the critical care lab, which is our core lab, remained relatively stable with no significant change. This contrast prompts us to ask what factors contributed to rapid responsible lab's improvement and why hadn't critical care lab made similar progress? Then there is James Lab, which operates with a much more strict turnaround time target of 25 minutes, which are significantly shorter than the 45 minutes threshold used for the other labs. Despite this tougher goal, James Lab actually achieved the best performance among all the labs, from 97 to 99%. Two key reasons stand out. First, it's close physically to the ED, which reduces the specimen transport time dramatically. Second, it processes fewer dilution samples, which are more complex and time-consuming to analyze. This background is important because raw numbers alone do not tell us the full story. Without understanding the differences in lab locations, workload, and workflow, it will be easy to overlook the operational factors that influence turnaround time. When we compare the 90% threshold turnaround time meeting rates for James Lab between 2023 and 2024, we found no significant differences. This suggests that James Lab maintained a consistently high level of performance across both years. While it's encouraging to see sustained success, this also raises important questions about the potential for further improvement. If performance is already near optimal, what strategies could we implement to push these boundaries even further? Alternatively, it may indicate that the current process and workflows are well optimized for the lab-specific context. James Lab consistently outperformed the other labs despite operating under a much stricter turnaround time, target of 25 minutes compared to the 45 minutes threshold used elsewhere. This high level of performance is impressive, but it's important to recognize that simply pushing the critical care lab and the rapid responsible lab to meet James Lab numbers may not be realistic or effective. Instead, we need to take a step back and focus on the root cause behind the differences in performance. For example, critical care lab and the rapid responsible lab depends heavily on the pneumatic tube system for specimen transport, which can introduce variability and occasionally delays that James Lab does not face due to its proximity to the ED. Additionally, critical care lab handles a higher volume of dilution samples, which require extra processing time and add complexity to their workflow. Based on the real-world practice, is there any room for critical care lab and rapid responsible lab improve the turnaround time? It's important to remember that the troponin assay itself has a fixed analytical runtime of about 10 minutes, as specified in the manufacturer's IFU. This is an important baseline that cannot be shortened. When we factor in additional time needed for sample delivery, specimen accessioning, preparation, and other preanalytical steps, especially at critical care lab, where transport relies on the pneumatic tube system and the sample complexity is higher, the feasibility of consistently achieving a 25 minutes turnaround time becomes much more challenging. This means that simply raising the expectations or imposing tighter turnaround time targets without accounting for these practical constraints risks creating undue pressure on the lab staff and workflows. It can lead to frustration, burnout, and potential compromised quality if labs are pushed to meet unrealistic goals. So it's important to balance expectation with flexibility. To further understand the feasibility of improving turnaround times, we tested the impact of lowering the turnaround time threshold to 40 and even 35 minutes in critical care labs. When we applied these more strict targets, the data clearly showed that critical care lab uh, was unable to consistently meet them. This finding reinforced our earlier conclusion that the current 45 minutes threshold is a realistic and appropriate benchmark for critical care lab, considering its infrastructure limitations and the complexity of the test process. Factors such as reliance on the pneumatic tube system for specimen transport, a higher volume of dilution samples, and additional pre-analytical steps all contribute to these practical constraints. By experimenting with tighter turnaround time goals, we were able to objectively confirm that simply lowering the threshold without addressing these underlying challenges is unlikely to yield meaningful improvements. Instead, this exercise highlighted the importance of setting targets that reflect the operational realities of each lab so that expectations remain achievable and support sustainable quality improvement. To better understand the performance beyond the simple average or pass-fail threshold, we adopted the IFCC recommended percentile approach. This method tracks performance across the 25th percentile, median, and 75th percentile for turnaround times, which allow us to capture low, median, and high performance months. By analyzing these percentiles, we get a much clearer picture of consistency and variability in lab performance over time. This approach highlights whether improvements are sustained or driven by occasional peaks. Applying this to our data, we see that rapid responsible lab demonstrate consistent improvements across all percentiles. This suggests that the positive trend is due to real systematic change in processing or workflows rather than random variation or isolated incidences. Then when we compare troponin testing volume between 23 and 24, between 2023 and 2024, we found that for each individual lab, including Rapid Responsible Lab, James Lab, and Critical Care Lab, the testing volumes remain relatively stable with no significant difference year over year. It's also notable that overall, Rapid Responsible Lab and James Lab handle higher volumes of troponin tests than Critical Care Lab in both years. The fact that Rapid Responsible Lab improved its 90 percentile turnaround time threshold performance without a reduction in test volume indicates that the gains were not simply due to handling less samples. Rather, these improvements likely reflect effective process enhancements and operational changes which drive sustained quality advancement. This combination of consistent volumes and improved performance highlights the value of our percentile-based benchmarking to capture meaningful progress and identify the best practice for broader adoption. Because we have both single-order and a one-hour algorithm troponin test, we conducted a more detailed analysis by breaking down the total turnaround time into two components, from collection to receive, which represents the pre-analytical phase, and from receive to release, which represents the analytical and post-analytical phase. This allows us to better understand where delays were occurring. In terms of collection to receive turnaround time, we observed the improvements at Critical Care Lab in 2024 compared to 2023, while the Rapid Responsible Lab and James Lab showed no significant change. When we look at the receive to release turnaround time, Critical Care Lab again improved in 2024, but performance actually worsened in both Rapid Responsible Lab and James Lab. We then further examined the data by checking the testing volume. Remember, we showed the testing volume in the previous slides. And with no significant change of test volume, this degradation in the receive to release phase appeared to be the main reason for the overall turnaround time delays seen at those two labs. This finding is important because, as shown in the earlier slide, Rapid Responsible Lab appeared to perform better on the 90% turnaround time threshold metrics in 2024. But when we look more closely, the actual turnaround time from receive to release had worsened. Since troponin testing volume remained stable in Rapid Responsible Lab and James Lab between the 2023 and 2024, the performance decline cannot be attributed to increased workload. What this tells us is that the 90% threshold metrics, while useful, may not fully reflect the underlying performance. It can mask internal inefficiency and delay trends, and therefore it may not be sufficient as a standalone quality indicator. This example highlights the value of having well-designed phase-specific quality indicators that provide more actionable insights and support effective root cause analysis. Troponin turnaround time here serves as a case study to illustrate how detailed data-driven indicators can support standardization and continuous quality of improvement in the lab. Sometimes, the standard quality metrics might not reflect or include project-specific improvements. A great example of this is when we brought clozapine testing in-house. Prior to this change, the test was sent out, leading to the long turnaround times, which sometimes cost a few days of turnaround time. Once we transitioned to in-house testing, the turnaround time dropped dramatically, which enabled the same-day results. This change had a significant clinical impact. Clozapine is a critical medication that requires close monitoring due to potential severe side effects, and the timely lab results are important for safe dosing and continuity of care. By localizing the testing, we support faster clinical decision-making and improve patient safety. However, Because clozapine testing volume is relatively low and doesn't fall under routine threshold-based turnaround time quality indicators, this improvement does not get captured in standard performance dashboards. This highlights a gap in how we typically measure and report quality. Not all impactful improvements are captured in the quality metrics. So it's important to make space in our quality reports and review for project-based improvements, especially for those that address clinical needs and reduce risk. Across our health system, we monitor the monthly specimen rejection rate as part of our quality metrics. We use a standard threshold of less than or equal to 1%, which aligns with widely accepted benchmarks for acceptable pre-analytical error rates. This metric is important because specimen rejections can delay care, require redraws, increase staff workload, and negatively impact patient experience. Using percentile benchmarking, our analysis showed that UH inpatient, James inpatient, and East consistently exceeded the 1% rejection rate threshold in both 2023 and 2024. This labs experience frequently low-performing months, not just occasionally outliers, which indicate persistent challenges that warrant further investigations and intervention. Although the improvements observed in 2024. In contrast, outpatient sites at UH and James demonstrate excellent performance. Their rejection rates remain well below 1% across all percentiles, reflecting both strong performance and consistency. These sites can serve as internal best practice models for others in the system, especially for identifying effective specimen collection and handling workflows. We also observed modest improvement in 2024 at Ross and among the samples labeled as unknown locations, which suggested some progress has been made, although further work may still be needed. This kind of benchmarking goes beyond a binary pass or fail view. It helps us identify not only which sites are over the threshold, but how consistently and by how much information that is essential for prioritizing the corrective actions and resource allocations in a data-driven, targeted way. We will break down into the specific reasons for specimen rejection, hemolysis, and clotting consistently emerge as the top two contributors, which accounts for about 50% of all rejection system-wide in both 2023 and 2024. These are persistent issues that reflect challenges in specimen collection technique and handling. Other major contributors include improper collections and quantities not sufficient (QNS), which often result from inadequate mixing, incorrect jaw technique, or the pull timing. These factors point to variability in phlebotomy practice across the locations. Our site-specific analysis reveals the NOST trends. For instance, UH inpatient and James inpatient show a reduction in hemolysis in 2024, which is encouraging. However, these same sites experienced an increase in manual errors, for example, improper collection, which highlights how fixing one issue can sometimes uncover another if underlying processes aren't addressed historically. UH outpatients, on the other hand, showed improvements in both hemolysis and improper collections in 2024, suggest that some workflow refinements which are working well. Meanwhile, the mislabeling and unlabeled specimens worsened in some areas, including UH inpatients, UH outpatients, and the heart center. Although there were improvements in James inpatient, James outpatient, and East. These findings highlight that root cause differ by location and error type, so a one-size-fits-all solution will not be effective. Instead, we need targeted interventions, which includes improving the proper phlebotomy technique, especially around the clotting and the mixing, or reinforce labeling protocols, and importantly, leverage the success from high-performing outpatient sites by sharing their workflows and practice across the system, especially with inpatient team. Despite the improvement of sample collection and handling process, lab practice is also an important contributor for rejection rate. A great case study is our experience with haptoglobin testing. According to the manufacturer's IFU, any samples with visible hemolysis should be rejected for haptoglobin. Following this guidance, our lab routinely rejects hemolysis sample for this test. However, we began receiving feedback from clinical teams questioning this policy, and also haptoglobin is a key biomarker for in vivo hemolysis. So rejecting hemolyzed sample seems not reasonable. If we cannot measure haptoglobin in hemolyzed specimen, it raises the question of if the test is clinically useful at all. In response, we designed a study to evaluate the true impact of hemolysis on haptoglobin result using our in-house analytical platform. We simulated in vitro hemolysis by mechanically stressing whole blood samples and measured the hemolysis index using the same analyzer and settings used for our routine practice. We also test if the prolonged in vitro exposure 30 and 60 minutes led to more hemoglobin binding that might affect results. The findings were reassuring. Across samples with hemolysis indices ranging from 1+ to 5+, the measured haptoglobin levels dropped by less than 20%. Even with prolonged exposure, the impact remained minimal. Given our lab's acceptability criteria of ±25%, we concluded that haptoglobin results were still valid and clinically interpretable up to a hemolysis indices of 5+. Based on this evidence, we changed our policy and began reporting haptoglobin results even when mild to moderate hemolysis was present. And as a result, the rejection rate due to the hemolysis dropped significantly. This example highlights an important point. Quality indicator analysis is not just about tracking rates and thresholds. The real value lies in investigating root cause and identifying evidence-based solutions that improve both analytical quality and clinical utility. So far, we have focused on the most common and system-wide causes of specimen rejection, like hemolysis, clotting, or label errors. But occasionally, we uncover less obvious or test-specific reasons that also deserve attention. One such example is hemoglobin A1C testing on our HPLC platform. When we first reviewed the data, we noticed that the rejection rate for hemoglobin A1C was unusually high, which was around 30%. Importantly, this rate reflects stricter adherence to the manufacturer's guidance. So on the surface, the lab wasn't doing anything wrong. But this raised a flag. Was such a high rejection rate really necessary? A deeper investigation into the instrument flagging system revealed more details, which we can see here. There were about 2% of specimens were flagged as having no hemoglobin A1C results. 32% were flagged for possible variant interference. 11% were flagged for high hemoglobin A1C and 6% were flagged for low hemoglobin A1C. These flags triggered automatic rejections. But this led us to ask a critical question. Do these instrument flags truly reflect unacceptable specimens? Or are there limitations of the instrument itself? As we dig deeper, we found that a significant proportion of the rejection were not due to poor specimen quality, but rather due to instrument limitations, especially how the analyzer interprets variant hemoglobin patterns or out-of-range values. For example, many samples flagged for possible variant interference actually produced valid results when confirmed with alternative method or interpreted with clinical context. These workflows were specifically designed to guide the lab staff in interpreting the instrument flags more accurately, helping them determine if a flag truly reflects a specimen error versus when it may be due to analytical or instrument limitations. By providing clear step-by-step guidance, these protocols help the lab understand when it is appropriate to reject a specimen and when it is safe to report results despite the flag warnings. And here is another algorithm workflow for hemoglobin A1C interpretation in our lab. After implementing the new workflow, we observed a significant reduction in the overall rejection rate for hemoglobin A1C testing, dropping from 30% to 21%. This improvement reflects more evidence-based decision-making rather than simplify following the automated instrument flags. A deeper look at the data reveals the key drivers behind this positive change. The rejection rate due to possible variant interference decreased dramatically from 32% down to 18%. Similarly, specimens flagged for high hemoglobin A1C values dropped from 11% to 7%. And those flagged for low hemoglobin A1C values decreased from 6% to 3%. The key takeaway, which is not all the rejections are equal. It's important to distinguish between specimen-related issues and instrument-related limitations. This kind of detailed analysis helps ensure we are not rejecting valuable clinical data unnecessarily and allows us to optimize both quality reporting and test utilization. These reductions indicate that the workflow successfully helped the lab staff differentiate between true specimen issues and instrument limitations, which allows more valid results to be reported without compromising quality. We have discussed the quality indicators evaluated by traditional way. Looking ahead, the future of quality indicators in lab medicine will increasingly be shaped by advancement in AI. AI-powered tools have the potential to transform how we monitor and improve quality by providing faster, more accurate, and more nuanced detection of errors. One promising application is the use of AI-enhanced delta check algorithms, which compare current patient test results to the previous results to identify inconsistencies that might indicate sample misidentification or pre-analytical errors. These AI-driven systems can analyze vast amounts of data in real time, flagging potential issues much easier and more reliable than traditional methods. As AI continues to evolve, its integration into quality monitoring process promise to revolutionize error detection and management across health systems, which brings a new era of precision quality control and patient safety. A good quality indicator is much more than just a number on a report. It tells a story. It reveals underlying causes, highlighting areas needing attention, and ultimately drives meaningful improvement in lab practice. Quality indicators help us move beyond simplifying measuring the performance to understanding the why behind the data, which enable the targeted actions that enhance patient care and safety. So quality indicators become dynamic instruments, not only measuring the performance, but moving innovation, collaboration, and sustained excellence in lab medicine. That's all from today's presentation. Any questions are welcome. Thank you very much for your attention.